That's it. Yeah. 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 Good morning, everyone. Thank you so much, and welcome to the Health Overview and Scrutiny meeting on Wednesday, the 11th of February. Agenda item 1 is apologies and welcome.
We don't have any apologies today, Chair.
Thank you very much indeed. Can I ask everyone to make sure that their questions are strategic, and we don't really want personal stories, but please do contribute to this meeting because we are all here to take part, and the health and well-being of our residents of Worcestershire is upper and paramount in all of our minds. Agenda item 2 is, we have apologies from the CMR for Health and Wellbeing, Councillor Bell. Thank you. Agenda item 2 is declarations of interest and any party whip. Any declarations of interest, please, members? No, thank you very much. Public participation is the next agenda item, and we don't have any this morning. So agenda item 4 is the minutes, which I have before me. We've got 3 sets of minutes to sign from the meetings on Monday, the 8th of September, Friday, the 10th of October, and Monday, the 10th of November. If your memories are that good, are you all happy if I can sign these as a true and accurate record, please? Thank you. So we have 2 main agenda items, one being the annual public health review and the second one being the West Midlands Ambulance Service. So I'd like to welcome the public health team. We'll have members in this room that don't actually know you. I do. Fantastic team that you are. Would you quickly just introduce yourselves so that other members know, please?
I'm Tanya Richardson, Consultant in Public Health at the County Council. I'm also Clinical Lead for Social Change at the ICB.
Hi, Elizabeth Griffiths. I'm a consultant in public health, and my areas are around adult health improvement, the community development work and creative health as well.
Hi, I'm Lisa McNally, Director of Public Health.
Hi, Matthew Fung, Consultant in Public Health, leading on data, intelligence and health protection.
Morning everyone, Andy Boot, Head of Service for Safer Communities, supporting trading standards, community safety and emergency planning.
Morning, I'm Claire Mitchell, Head of Service in Public Health for Pregnancy, Early Years and Families.
Good morning everyone, Lucy Chick. I'm a Head of Service in Public Health as well, but I'm covering 5 to 19 year young people and also have a role in suicide prevention.
Hi, Sam Collison. I'm Strategic Programme Manager in Public Health, so my work supports across the team.
Thank you all very much indeed. And to the rear of the team for Public Health is Councillor Sue Eacock. She's a Cabinet Member for Adult Social Care, so welcome and thank you for your attendance this morning. So I'm going to hand straight over to Dr Lisa McNally, please, to take us through the annual review of public health in Worcestershire.
Thank you, Chair. I won't do a long intro because I'm sure you've all read the paper. This is a report on the year 25 to 26. We've enjoyed our year. I think some of the highlights were that we reported a significant reduction in preventable mortality, which is a measure of I suppose the overall impact of public health, because what we try to do in public health is enable people to live longer and healthier, and so people not dying prematurely from illnesses that are preventable by public health action, which is how that indicator is defined, then obviously that was really good to see. More specific things that stick in my mind is I did a lap of honour around the office when we saw the big fall in smoking rates, smoking prevalence, which equated to about 1/3 off the number of smokers in Worcestershire, which is really pleasing given how much work we've put into enabling people to quit smoking and the slight shift in approach that we took in that. It was great to see Healthy Worcestershire produce really good outcomes with a very high net promoter score, which means that people are not only benefiting from it, but they're loving it as well. And that's what we want people to do with our public health programs, is have fun. And yeah, and this year also brought the council the National LGC Public Health Award. So I just want to, I won't say any more except just a big thank you to the people around me who are easily the best team I've ever worked with in my whole career, and probably ever will. And a big thank you to the elected members here who have been so instrumental in our work. As I look around, I see so many people who have given us ideas for work in the community, or have helped us shape programs in the community. And with you guys as elected members being so close to your local communities and local population, we're eternally grateful for all your positive input, so thank you. But other than that, let's start the questions.
Thank you very much indeed, Dr. McNally. And thank you for all the work that you do for our residents. This preventative work, actions we're taking, we will see in the years to come. So your legacy will be never forgotten. So, questions please, members. Who would like to start off? Councillor Fordington, please.
It's a question directly to, well, it's working with second-hand smoking, if that's okay, Lisa. Right. I've actually got some letters which I've actually been communicating with the MP, and obviously I've actually got through to the House of Commons as well. It's to do with second-hand smoking. And I like to just read something, if that's okay with you. Just bear with me. Second-hand smoking. It's just not smoke, it's poison. Over 7,000 chemicals straight into tiny lungs. Kids with asthma, not a flare-up, a fire. Coughing, wheezing, gasping, hospital again. Lungs don't read address labels, they just burn. Divorced, separated, same air, same child. One home smokes, both homes lose. But here in Worcestershire, we cut smoking by a third. 1 year. Thank you, Lisa and her team. So don't tell me we can't. We can. Smoke-free, both homes. Excuses end today. Can we lead one more child wheeze in the dark? No. Will you stand with me? Every child safe, every breath clean, every parent lungs over lighter. Thank you.
Thank you very much. Dr. McNally, could you respond to that, please?
Thank you, Councillor Fordington. There's not much to disagree with there, and I love the words you used, very powerful. We know second-hand smoke is dangerous. We know it's particularly dangerous for children. Everything from asthma, bronchitis, permanent damage can be caused to children, especially younger children, through second-hand smoke. So it's a major issue that we need to keep on top of. One thing we have been focused on a lot, and I might ask Claire to come in after me to talk about the work we've been doing, not just in helping pregnant mums stop smoking, but also to keep them off cigarettes after they have given birth. And of course, we work with not just the mum, but often the whole family to better enable them to provide a smoke-free home for their young children. But I won't take up any more of this because it's Claire's brilliant work that has led the smoking and pregnancy work, so I'll hand over.
Thank you. I completely echo the importance of especially keeping babies away from second-hand smoke. As Lisa said, we set up a specific smoking service within our health visiting team a few years ago. You may have heard of our smoke-free home service offer. We wanted to, as well as our universal smoking services, make sure we've got a really focused offer within our health visiting service. So within each of our mandatory contacts that health visitors have from birth through the early years, we have integrated within the contacts to ensure we're having conversations about smoking, and we have the direct referral route to the service, which is embedded within the health visiting team, which we thought is really important. So we're not signposting out to external services. We've got, for that really core focus for the first few years, that service sitting alongside the health visitors. And that service has been going from strength to strength over the last couple of years. We've had an increase in referrals, but also our quit rates have been increasing over the last few years. And more recently, we've been extending that service offering to our family hubs. So we've got smoking champions within our family hubs and resources, and a lot of healthy homes related events and services. So we've got that system-wide focus on ensuring those first few years we've got that smoking offer to parents that are wanting it.
Thank you very much indeed, Claire. Any further supplementary question you'd like to ask, Councillor Fordington? Okay, so you can see that it's a key criteria for the work we're doing in public health. Smoking cessation is up there, right up there, and we're achieving good results. Thank you very much. So the next person to ask a question is Councillor Wilde, please, then Councillor Turner.
Thank you, Chair. I want to give a huge thanks to your team and everything you do. You're always really approachable, and as you said, you take on board the things that we say as well. So that's brilliant. But there's always scope. So that's sort of the point of these questions. So I've got two questions, but maybe I'll ask the first one. So given a sharp rise in child poverty in Worcestershire, which specific public health interventions in this report are reducing health inequalities, and how will success be measured over the next 12 months?
Thank you.
Such a fundamental question. I don't need to tell anyone on this panel that there's a linear relationship, a real link between poverty and poor health outcomes. And that is no more sharp than amongst children and young people. We have a number of programs that try to directly mitigate against the effect of child poverty on health. I think probably the most notable is our Family Hub programme. And so, Claire, warning, I'm going to be coming to you again in a second. The family hubs are deliberately located in areas where there are big challenges with deprivation and with poor health. And of course, we all know, don't we, in local government, that if you want services to be accessed and utilised fully, locate them in the right place. Don't expect communities to come to you. We need to go to communities. Those family hubs offer a range of programmes to improve child health and parental support, which Claire will say more about. We've also got our work around the health visiting and school nursing programme, as well as, of course, the youth services, which Andy has spoken about before and can tell you more about today. Everything we do in public health follows Michael Marmot's principle of proportionate universalism, which is a long-winded term for saying that you do more where the need is, where service delivery, where support, where investment is highest, where the need is highest. And of course, the final thing I'll mention is that approach is epitomised by our Priority Neighbourhood Development Programme, which invests not only money in areas where we're seeing the highest health challenges, but also invests a whole load of trust, because we let residents, community members, parents come up with their own ideas for health improvement, and we put the resources in then to help them make those ideas a reality. So if I, for more detail, hand over to Claire, and then maybe also Andy to say a little bit about some of the youth service innovation that's happening.
Thank you, Lisa. Claire, please.
To add to what Lisa said about family hubs, that's been an expanding work programme over the last couple of years, but with the new Best Start Family Hubs funding coming in, it's going to be expanding even further. It's focused on our priority neighbourhoods and our communities that are most at need. So in its essence, our framework of 0 to 5 and 0 to 19 services are based and focusing on those families that are most in need. But we also work on quite a district level to be able to ensure we've got networks that are working with each of the districts to identify which particular neighbourhoods within each district require further support and intervention. We take a data-led approach with our LSOA data to really dig into which neighbourhoods and which communities we can focus our work at. So family hubs are universal in their offer in terms of the range of support that they offer families through the early years. In terms of the more typical health services you might expect to see, health visitors, speech and language, maternity services. But we often find that family hubs aren't just the universal offer of support for families, but they can often be a front door for families at crisis. We often have a lot of families attending our family hubs for food bank vouchers and food parcels, Healthy Start vouchers. So we do have, and more recently, we do have quite a lot of footfall within our family hubs for families experiencing poverty. So it's not just supporting families with the kind of direct financial support in terms of linking it with services and vouchers and interventions. It wraps that kind of holistic view around families in terms of the wider impact that can have on their well-being, on their health, and it provides that holistic support offer for families, for those experiencing financial hardship, but also those universally as well. Just to add specifically a particular work programme that we are really focusing on in public health over the next year or so is our Healthy Start vouchers. So I'm not sure people are aware, but nationally and for many years there's been a programme called Healthy Start, which offers families which meet certain criteria, free food vouchers and vitamin vouchers. And we find that nationally, not all families that are able to access these vouchers are accessing them. They don't all know about the programme, and there's been quite a push over the last few years, not just locally but nationally, to increase the uptake to Healthy Start. So we have worked over the last few years to do that locally, and there is going to be a particular push over the next few months to do a focused campaign and ensure that all families, all professionals, and it'd be great to ensure that all counsellors working in the areas are aware as well, who can access the vouchers, and ensuring that families that can access money each week to use at any supermarkets to access free food it doesn't need to just be fresh food. There's quite a range of things that you can access with the vouchers because there are hundreds and thousands of pounds that Worcestershire families are missing out on that we can support them to access. So we have a webinar coming up on the 24th of February for anyone that wants to just understand a bit more about the Healthy Start scheme and how we can really provide that targeted support for families that might be able to access it. So happy to send any more information. That's a professional webinar, professional, public, anyone that wants to access that. So we can send the details around.
Thank you, Claire. Claire, could you send the link to that webinar? Conscious at that time of the year, we're all doing budget setting in whatever form we're doing it, be it district or county. Yeah, if you could record it and send the link round, I think it'd be really important because it's about accessibility. Thank you very much. Andy, please.
Thanks, Councillor May. So, youth work is a massive area of work for us and has been for a long period of time. The Council has a statutory duty around youth work, and that's to ensure sufficient access to youth provision across the county. And in Worcestershire, we take a really evidence-based approach to our youth work, so we work with our district colleagues to shape the local offer within their patch. So we're working with services in local areas to ensure that our youth offer is accessible to local people in that area. But really central to that is the voice of the young person. So it's not about people like me or professionals in that area shaping the youth offer. It's about young people telling us what they want in their area, what activities they want to be able to access, when they want to access them and where they want to access them. And then it's about us as services working together to make sure that becomes a reality. In each district within the county, there should be 3 types of youth work opportunities on offer. So there'll be the open access youth provision that we'll all be really familiar with, so the traditional youth work offer in youth houses, etc. There'll be detached youth work, which is where we have, if you like, roving teams of youth workers going out and meeting young people where they're choosing to meet, which could be shop fronts, it could be bus stops, but then working with them to find out what about the youth offer isn't working for them and how can we tailor that to better meet what they would like to see. But in parts of the county, we also have one-to-one mentoring, so we have youth workers who are going into schools and working with young people who are at risk of exclusion, who aren't participating fully in school, but offering really targeted one-to-one mentoring support to those young people. So we have a real myriad of approaches in terms of youth work and working with our young people. If I could just finish with 2 further points. During this last 6 months, we've agreed to add 50% to our investment in youth work over the next 3 years, and that will be focused primarily on detached youth work. So that is, we have our youth houses, we have our fixed youth offers we're pretty confident with across the county, but in terms of detached youth work, going out where young people are meeting, we recognise we could do more, and we're looking to put more investment into that over the next 3 years. So from the spring of this year, that will really kick in, which is really exciting. You'll also may be aware that in December of last year, the National Youth Work Strategy was finally published, which was really exciting. We've been waiting for about 5 years for that strategy, and it finally arrived, which is great news. But a lot of the content within that strategy is really encouraging. So it talks about new investment, it talks about repairing a decade of cuts to youth work nationally, it talks about improving access, but really importantly, it talks about improving access to qualified youth workers and improving access to trusted adults. So to our most vulnerable young people, making sure they've got a trusted adult to go and have a conversation with, which is so important.
Thank you very much indeed, Andy. I think that the one area of this is sustainability in terms of youth work as well. You can't turn the tap on and off. And your key comment about enabling people to have influence on what happens, don't do it to them, enable them to succeed. And that's the key component across the whole of this. It's probably the greatest learning I ever had when I worked with you guys. Thank you. Dr. McNally, please.
Yeah, definitely agree with that, Chair. So Councillor Wild's question also importantly asked about how is it measured? So there's a whole host of measures we can employ. I think important as a proxy for overall health impact is unplanned admissions to hospital of children 0 to 4, etc., and emergency room visits, etc., because they're a proxy for when things go wrong. Councillor Fordington, for example, raised the important issue of second-hand smoke. Well, that can lead to chest infections, etc., which would land a child in hospital. So far, the data looks good. We are significantly below averages, all averages for children's admissions to hospital. Referencing Andy's work as well, the youth service work, an important part of that is crime prevention. So we've seen a decrease in first-time entrance into the youth justice system. So there's a whole host of measures, and they're looking good at the moment. But I'd add a caveat that no public health programme can insulate children completely against the devastating effects of poverty. And unless we as a society take that seriously, then the impact of poverty is just too powerful and too strong. So the measurement is looking good at the moment, but no matter what we do over here, and no matter what you guys do as elected members, if children continue to live in poverty and more poverty, then there's no public health programme that can protect against the impact of that. So I just wanted to add that wider point that, we need to address this at a root cause level.
Thank you very much indeed, Dr. McNally.
Can I add to that as well? Thanks, Lisa. Admissions for children obviously is a really great outcome measure that you can kind of look at, but there's lots of process measures and proxy measures that you can look at in the meantime as well. So we've already mentioned some of them, uptake of Healthy Start vouchers. You can expand that to things like household income, school readiness, and achievement for those children eligible for free school meals. So you can really do some targeted measuring and targeted work, which may lead to some of the other outcome measures that we're interested in, like admissions or children coming into care at the very kind of serious end of the spectrum. From a health protection perspective, when you think about health and deprivation, immunisations, as we've talked about before, is also a really important metric, because we know it's an evidence-based, one of the key evidence-based public health interventions to improve the health and well-being of children, and arguably their families as well. So lots of other things to think about, but it is multifactorial and requires very much a system drive to address what is really a wicked issue, because if it was easy to solve, then it would have been solved.
Thank you very much indeed, Matt.
Just follow up slightly.
Can we be really... the only
I'm
reason
just
I'm
going
saying
to blend into my second question. So moving on from that, one of the measurements I've just been thinking about would be, it would be good if we didn't have food banks and we didn't need them. And my daughter works in one, and I'll be getting rid of her job, but her ambition is that she doesn't have to do that. So that's one way of measuring. But looking into the future, how confident are you that these improvements are sustainable? And I noted you use that word. And what will the impact be if the funding, and this is crucial, is reduced in future years?
So I think whenever we design a programme, we build sustainability in mind. So, for example, we've talked in this committee before about the Priority Neighbourhood Development Programme, where we don't just write a cheque, bung some cash to an area and then walk away. We work with the community in those areas to ensure that we've all got an eye on the long term. So a good example was the work in Westlands, which we gave an initial large financial resource to the working group of residents who delivered that brilliant programme. But we also guided them in terms of seeking more funding and setting up programmes that are sustainable in the long term. When Sam there and her team assess grant applications, we ask two questions. Is there a link with health and well-being? But also, how sustainable is this work? Are you doing things that will continue to keep giving in the future? If the funding stops, then yeah, that brings sustainability into question. And it would be a false economy. When you disinvest in prevention, you cause more cost. It's simple as that. And you don't need scientists or public health professionals to tell you that. It's absolutely obvious that we can't just continue to build services up and up to take more and more and more demand. Because where does it end? We have to get serious about prevention in all departments across the council. And that's not just good for the bank balance, but it's also good for residents because prevention improves quality of life. So yes, I worry all the time about disinvestment in preventative work, as you would expect me to.
Thank you very much, Dr. McNally. Councillor Turner, please.
Yes, I'd like to thank the board for all of the good work they're doing, and particularly with Claire, with young pregnant mothers. My daughter is 37 weeks pregnant today, so I've been sort of engaging with her and all the processes she's going through as far as her journey is concerned. And she's joined an NCT group, which obviously does come at a cost. And we know prevention and education is very important. And we were talking about cigarette smoke and so on, and the consequences that could have on unborn children. And I'd wondered what your thoughts are as far as vaping is concerned, and the unknown consequences of vaping, because maybe people perceive it is a better alternative to cigarette smoking, but there are still unknown consequences for vape smoking, and obviously second-hand vape inhalation as well. Thank you.
Claire, please.
Yeah, we do have the inclusion of vapes within our smoking cessation services, along with wider NRT. And that's in line with our national guidance that it is a much safer option than smoking. And we only ever would encourage vaping as an aid to quit. We're really careful within our services that we don't just use vapes as an aid to quit. We use them in a way that we are also supporting people to then come off vapes. We would never encourage vapes as part of a long-term use plan. It's always a short-term aid to quit, and we ensure that we procure vapes that can go down to the 0%, and we can ensure that families also have support to then come off vapes. So we do use vapes as an aid to quit with our services, and it's been really successful to increase our quit rates, but we are very clear in Worcestershire with our policies within our services that they are very much that, an aid to quit and nothing else. We would never encourage the long-term use of vapes, yeah, that's our position across all of our smoking services.
Thank you very much, Claire. And as a starting point, don't start vaping at all. It should be a step down from smoking. Thank you. Councillor Jenkins, please.
Thank you, Councillor Mayor. Thank you, everyone, for your report. My question was very similar to that. It kind of follows on from, because lots of young people, I know my kids at high school, they are vaping, they're not smoking. So the data about, in paragraph 10, about reducing rates of smoking, can I just clarify, is that just smoking or does that include vaping first?
That data is about tobacco smoking.
So in that case, well, I'm thinking maybe a lot of young people are vaping, they're not smoking at all. You're focusing on stopping them smoking. You maybe are missing them, they might be vaping, they're not using it as a step down, they're just using it as it's a cool thing to do, you vape. So is there any kind of focus to maybe tackle vaping as well whilst pregnant? Because we really don't know much about the impact of vaping, because it's, who knows what the chemicals are in there. We haven't got maybe the data that we've got with smoking, but it's a big unknown. So thank you.
Yeah, really good question. And we take a two-pronged approach to reducing vaping amongst young people. And it's really a supply and demand two-pronged approach. So on demand, we've done a lot of work in schools with some very proactive head teachers, actually, who have helped us get messages into schools. And we worked with the school children themselves to design messaging, posters, discussions around the harms of vaping. And of course, that's important to work with young people, because I'm not cool, as my team often remind me, and haven't been, or in fact, probably never was. And so I don't understand what's in children's heads around vaping. And it was interesting when I was talking to a young girl in one of the schools, and we were choosing posters about which one would be most effective in turning young people away from vaping, and I chose the wrong one. She said, no, actually, that will encourage it. They're the ones you want to put out. So that was good. But even more important, I think, is the supply side. And we have put a lot of time and a lot of effort into busting rogue retailers who will make a profit on the back of kids' health by flogging them illegal tobacco or illegal vapes. And young people, if they buy a vape, there's a very good chance it's an illegal one, because if a retailer is willing to break the law by selling a vape to someone underage, why wouldn't they sell them one of the unregulated ones that contain all sorts of nasty chemicals? So the Trading Standards team has been out with the police and the sniffer dogs, not just catching the retailers who do this, but now we're closing them down. We invested some money into Bromsgrove Council, actually, among others, for the legal capacity to pursue the closure orders through the courts, which, as you can imagine, takes time and effort. It's no good taking away a retailer's stock of vapes if you're not going to do anything else, because he'll just order more. They'll be back there in the shop the next day. So if you sell illegal vapes, illegal tobacco, or any of those products to kids, we'll close you down. and retailers know that now. So that's our two-pronged approach to this.
Thank you very much indeed. It has been very successful in Bromsgrove. We currently have 3 premises that are closed, and the hope is that you displace their market and they give up and move away. Councillor Jenkins, is it a quick supplementary? Because I've got a great long list here.
Go on, I'll let you carry on with that.
Thank you so much. Thank you for your understanding. Councillor Oodle, please.
Yeah, I think public health is cool, if that helps. Chair, I did have 3 questions. Do you want me to only prioritise one? Okay. Sadly, I'll throw away the other first 2, but the most important question I have is about mortality risk for children with cancer. And I've just come across a very frightening statistic, which children with acute lymphoblastic leukemia, which is the highest form of leukemia for children, if they live in high poverty neighbourhoods, face up to a 55 to 80% higher risk of mortality. 55 to 80% increased risk if they live in poverty of not surviving their leukemia. What kind of work are we doing to actually address that startling statistic that if you're going to be born with leukemia in parts of the division I represent, you're more likely to die than if you are in a neighbouring division? That is really frightening to me, especially as I have had family members with leukemia. So there's a clear link. And how do we address it, especially with other health professionals, using your professional experience? How do we address that kind of startling statistic and try and reduce it?
Yeah, thanks, Councillor Udall. It's quite a stark set of data, isn't it? And of course, it goes for a whole range of health problems. If you are poor and have an illness, you're more likely to die from that illness than if you're rich with an illness. And we could probably do a whole meeting on the factors there. I think firstly, it's about getting support networks into areas so that when people have symptoms, have a condition, they can seek help. It's about making sure transportation is in place to enable people to get to hospital appointments. There's a whole wide range of factors. In terms of influence on the NHS, we are involved in that in a big way. So around the Priority Neighbourhood Development Programme, what we're asking our NHS colleagues to do is reorientate their services to our areas with the highest health inequality. And that is sometimes easier said than done, but they are really showing willing. I think there are some areas, for example, without a general practice. There are some areas where people don't have the transportation to get to the hospital appointment. If we keep it like this, we will keep getting those statistics. Addressing health inequality is in everyone's interests. If you live in an affluent area, it's in your interest that the person a mile down the road in the deprived area gets better health and social care support. It's in your interests as well. So I think, because no man is an island when it comes to health. So I think, yeah, we're working with the NHS. I think neighbourhood health provides a real opportunity for this, the new big programme in the NHS. We need to work hard as a system to orientate our services more to areas that need them the most. And then, just maybe, we can start to see a levelling off of that inequality.
Thank you very much indeed for that comprehensive answer. Councillor Ward, please.
Thank you, and thank you for your presentations. I've got a quick question. I think Matthew mentioned it briefly on immunisations. And in the report, the measles documentation we're one of the highest uptakes in the area, which is great. But I want to know what the results of the interventions that we've had are on the uptake. We've got 2023-24 figures of 90% secondary uptake. I'm curious to what the interventions we've already done over the last few years have resulted in what sort of improvement? And how does that relate to nearby areas which might influence or affect the herd immunity of particularly measles? Thank you.
Can I just come in before I come to you, Matt? Because as an addition to that question, I was at the Local Government Association Health and Wellbeing Board yesterday speaking about immunisation. And the UK has lost our status as having eliminated measles, which to me is of grave concern. But also, come April 2026, the Integrated Care Board will take over the immunisation programme at a time when we've got lots of churn in the system with local government reorganisation and the district and the county councils both going away and a new unitary being formed on whatever footprint. My question is, how are we going to address this? Because the Integrated Care Board has a lot of demands. It's had a 50% cut in its funding. It's now over a larger footprint. How will we get down to the granular detail to address the issue that Councillor Ward's just raised about immunisation and finding those pockets where people aren't going and having their regular immunisation programmes, please? Thank you.
Thank you for those questions and the interest in vaccination. So back in 2024, we started to see a bit of a change in the picture around measles cases, particularly in Birmingham and around other parts of the country. Not necessarily in Worcestershire. I think at the time we may have had 1 or 2 cases at most. But it led us to think, actually, we want to, although as a country we may have lost the status of kind of measles elimination, but as a county, our levels of immunisation are actually very good relative to many other parts. And what we wanted to do was maintain as high a level of protection for our population as we can. We can't control what goes on elsewhere, but we can control, to a degree, how easy it is for people to access vaccinations locally. And that's where we started to use libraries and different venues to offer vaccinations directly into communities. And that's what we did in 2024. Now, you asked how many people were vaccinated as a result. It's difficult to kind of answer that fully because we know that we vaccinated about 170 people back in 2024 who were totally unvaccinated. But the campaign itself will have led other people to get vaccinated at their GP surgery or by other clinics that weren't ones that we ran. So it was at least 170, but probably a lot more than that. This year, we decided to rerun that campaign because we were starting to see some cases rising again in some of our neighbouring areas. And we know that we're not just an island of Worcestershire. There is a lot of cross-flow of people and families and connections and friendships and work and whatever. And so it's kind of silly just to think, actually, our levels are okay, let's just leave it. We wanted to do the same again and to push again. We managed to get some funding through NHS England to run this latest campaign. So we're using family hubs, we're using libraries, we're getting right into communities, we're trying to do some more joined-up work with other teams like sexual health as well within their settings. So essentially, I would like to see hundreds of children and young people get vaccinated, not just for MMR, because we've actually expanded it this year to flu and also to HPV as well. So these are really important vaccinations that we're offering people. and yeah, we're right in the middle of the campaign though, so we'll report back, if you're interested, how that goes at the end. So that's where we are currently.
I would be interested to see what actual improvement is from 90.6% actual data to see what effect and what improvement we have at least in our area of the effects of the programmes that you've done over the last few years.
Thank
Absolutely.
you, Mark. Sorry, Matt, can I just get confirmation? Isn't it 95% immunisation rates that we require for herd immunity?
Those are the World Health Organization targets that we're meant to be trying to achieve. Yes, that's correct.
Okay, so coming back to the point and building on what Councillor Ward's just said, how are we going to influence areas like Birmingham when our functioning geography in the north looks to the north? We've got pupils that come into Worcestershire to be educated. They're Birmingham based and raised. And we have this cross movement, as you've just described. How do we get this message across? Because as you've so rightly said, we're not an island. We need this commonality on message. And who's going to step up? Because I'm really concerned. Our Integrated Care Board footprint is Coventry, Warwickshire, Herefordshire, Worcestershire, and yet we look to the north into Birmingham and beyond for our employment and education.
Absolutely. Proof that no man is an island when it comes to health. So the latest data on MMR, and this is for 2 doses, the Herefordshire and Worcestershire project, which we work on, is the highest in the region and also the highest amongst our statistical comparators in the high 94%. So, and of course, herd immunity is not a binary thing. You don't not have it at 94.9, but you do have it at 95. But it's an important ambition, nevertheless, to Birmingham's, according to the latest data in the Public Health Outcomes Network, has fallen significantly and is at 80%. So one thing, Matt really impressed me one day when he was first setting up the pop-up clinics, and he was almost like a general organising his forces, looking at the maps and getting these pop-up clinics, and a lot of them were along the northern edge of Worcestershire. I will say, I think Birmingham face a bigger challenge than us. I think their population structure is a structure where you would traditionally see lower vaccination rates. So I don't want to criticise Birmingham. I know the Birmingham Public Health team work incredibly hard trying to increase vaccination. But I think we just, in order to maintain this, I couldn't have been more annoyed when I saw that the UK had lost its elimination status. We worked too hard for that, and unless we get that back, more children are going to contract measles, and it's a fatal illness in many cases. You know, it's not something that's just a mild illness that will pass and not something to worry about. It's not a part of growing up. It can be a really serious illness, so we need the whole system to be behind this. We will continue to share what we do with other areas as they do with us. And yeah, I just hope that as a region, we can pick ourselves up from this.
Thank you, and I hope as a region we can extend our influence as well to encourage. Matt, did you want to come back in?
Yeah, just one really quick comment. You know, it's not just about those people who are coming for vaccination and kind of raising awareness. I'm getting direct messages from people across the community who are literally emailing me saying, thank you so much for this. I'm immunocompromised. I'm not a vaccine responder. And what we're trying to do is protecting me as a person. So you can see then how actually vaccination protects the person in question, but also people that they're in contact with. And that's the second point of vaccination really for me.
Thank you very much indeed. Councillor Wells, please.
Chairman, thank you, and good morning, everyone. So I want to take you back to 1942. Does anyone own up to knowing anything about 1942? Well, let me tell you one thing that happened in 1942. William Beveridge produces reports which form the basis of the welfare state and the NHS. And he identified key determinants of poor mental health, poor health generally. Now, what I'm interested in today is the thing that isn't on here, and that is housing, and squalor in particular, because squalor was one of his 5 issues that formed the backdrop to the NHS. Now, I realise it's not a direct function of this council. However, it's my experience, and maybe others, particularly in the private rental sector, that there are people living in Worcestershire in very, very poor conditions. And there's clearly a relationship between squalor and poor health. I just wondered if there's a comment.
There certainly is. I'm going to take you back to 1854, Councillor, because I'm competitive like that. When a man who is considered the father of epidemiology, John Snow, not the bloke from Game of Thrones, but the epidemiologist, his career was about tackling squalor. He was one of the first medics to identify how living conditions, often it's said that health is not so much about the conditions we have, the health conditions, but the conditions we live in. That's what determines health. And he was there, and he ended up taking the handle off the pump in Soho, the water pump. Do you remember? Well, not remember. You know, do you remember reading? Do you remember reading about it? But to answer your question, I couldn't agree more. But public health is about the conditions we live in. There's not much this team around me can do for your health if you're living in mouldy accommodation, if you're living in accommodation that gets incredibly warm during the summer and can't ventilate, or incredibly cold during the winter. There's not much we can do in public health if you are completely socially isolated because you're living at the top of a tower block. Housing is a fundamental driver of public health. And I'm really, one good thing I suppose about LGR, whether we end up with 1 or 2 councils, is that housing will be in the same organisation as public health and indeed other important disciplines like social care. Because unless we address housing, we won't be addressing health. We need to get a grip of that. So thank you for raising it. It's something I feel passionately about.
Thank you very much indeed. Councillor Jenkins has just...
Could I make one comment? It's a great question. I was going to take you back to 1838 just to beat Lisa, but I won't go there. We work really closely with Worcestershire. We part fund one of their key posts. And that work is set up to try and get grants to people who would benefit from things like home upgrades. If they can't afford it, if they're living with certain benefits, etc., they're able to get insulation and heating upgrades, etc. So that's that. There's also something coming along called the Crisis Resilience Fund. I don't know a huge amount about this yet because it's just being set up. But again, there are national level pots of money and grants that I think will not solve what you're talking about. I think that's one of these wicked issues that we can't solve everything, but we can support some of the hardest hit households and homes with some of these grants that we can distribute. And we're just figuring out how to do that in the most equitable and best way for our population.
I don't like the renaming of that fund. It was the Household Support Fund, and I don't like anything that carries the name crisis, because I just think it puts people off actually applying for it, but that's my own personal thought. Right, Councillor Jenkins said 2 seconds he wants to ask a quick question, but I'm going to be really tight now, because we're drawing to the end of the hour, and I want to make sure everybody's voices are heard.
Okay, thank you, Chair. Matthew made largely the point I was going to make, but there is the Warm Homes grant that is available, and I have an example of a resident whose house had black mould and lots of stuff all over it. Now it's all been sorted because he's had new boiler, insulation, solar panels. So recommend that and get everyone to do it in their division.
Thank you for that recommendations. Thank you very much. Councillor Kumar, please.
Thank you, Chair. Good morning, everyone. May I want to congratulate you all, Dr. McNally and her team, for all the work you do throughout the year for not only the public, but councillors like us who come up with projects to you and you support it wholeheartedly, which helps the community. So thank you so much for that. Coming back to this paper, I think it's an excellent paper, which I like to read. Could have been 200 pages worth, but I'll just make a few comments about it. It's a very comprehensive, evidence-based, with clear recommendations, with collaborations highlighted. Just a couple of things which I thought which was missing was limited details of implementation. Okay, this is just a 24 pages, but we haven't got time for it 200 pages. But people would like to know how things were implemented and how the resource constraints, you've mentioned a little bit about it, how the resource constraints will be overcome if you start a project. How will it be fulfilled? That's something which I needed to know about. And the last thing about it is, yes, you do talk about successes, which we love about it, but what it does, it hides behind our failures. So we also need to talk about not only our successes, but the failures and the lessons learned from that. That is something which we would like to see in the paper next time. And Chair, if you got 1 minute or two for me, I have a couple of points to make about a mental health and health equalities. Is that okay? Right. So would you like to answer that and then I can come back?
Yes, thank you, Councillor Kumar. I'm not sure. I mean, there are things that haven't gone as well as we would have liked them to. You know, you can see the outcomes. We'd obviously like them all to be green, I think for me, the biggest area that we haven't made enough progress on is, I think it's our work on issues like obesity. The problem is we don't have very good data on adult obesity, especially. The child obesity has reduced, but it's still too high. But I think adult obesity is something which I'm not happy about in terms of our progress. It's very difficult though, because we don't want to stigmatise, and we've always been very clear that we don't want, I don't even like the word obesity. I think it's too stigmatising. I think we need to do more to enable people to have the opportunities to manage their weight. But yeah, I think that's one area where I think we could have done better, and certainly an area where we've got plans to address that. But just to emphasise, we must never stigmatise obesity. I don't think we should stigmatise any public health issue. I have wholehearted empathy with people who smoke, because I used to smoke myself, and it's a nightmare trying to give up. But I think if we just keep up the positive messaging, increase the opportunities for physical activity, which we are going to be doing, and also talking to the NHS about the use of GLP-1 medications. They're a controversial topic, but for many people, they represent a real breakthrough in terms of how they can finally address their obesity. They do come with issues including rapid weight gain when people stop using the medication, and that's why we need to combine GLP-1 medication with behavioural programs and programs to help people to sustain weight loss. But it's very difficult to get access to them at the moment. And here we are again in the UK creating yet another health inequality. Because if you want to benefit from GLP-1 medication, you have to be able to afford the monthly prescription of 200 quid or whatever. So there we go again, reinforcing health inequality. I don't believe that we should ditch GLP-1 medication as an avenue, either because it's expensive or because there are issues around weight gain afterwards. We need to harness every bit of new science we have at our disposal and acknowledge that people living with obesity find it incredibly difficult to address it. So let's help them with everything we've got.
Thank you very much indeed, Dr. McNally. Just a quickie, because I've got two more.
Yeah, I think coming back to, again, a good work on mental health, I've got a couple of points to raise about it. What is missing is, yet again, limited evaluation. I think you start off some programs. What are the, again, we talked about outcomes and impact, and how are these people followed up in the long term? That is something we need to look at. You started off 6 weeks program on mental health. What happens to this person? Something we need to look at. Is that program successful? And the second point is about access to and barriers. For example, people living in the villages, are they able to get the same kind of treatment as it in the cities? Thank you.
Thanks, Councillor Kumar. It's interesting, we're literally just in the process of working with the Health and Care Trust to review their data on mental health services. We've started with talking therapies and doing exactly that, tracking people through from referral through to the process of going through treatment and through to their outcomes. And what we'll be doing is feeding, well, we have fed that data straight back into the service, the findings that we have identified. And they will be making changes to talking therapies based on that analysis. So this is, for us, it's kind of that analysis, that information, that data for action. It will change the way in which people get into a service, because there are differences, you know, if you self-refer versus if you get referred into a service, if you come from a white background or a black background, if you come from deprived or affluent backgrounds. All of those factors will determine the success of your treatment. So that's what we're trying to shift the NHS towards, and our colleagues in the service, and they've been really receptive to it, I would say.
Thank you very much indeed, Dr McNally. Thank you.
Councillor Kumar makes a really good point about evaluation. So in programmes like Healthy Worcestershire, for example, we take regular reports on that data, and we've showed that has improved mental health. For as long as it's been going, we can obviously only evaluate a programme, but that does seem to be leading to sustainable improvements in mental health. We also have the personal well-being measures, which are national surveys on things like life satisfaction, anxiety. They've been improving, except for one area, Redditch has seen an increase in anxiety, especially among women. So this is one of the reasons we're working so intensively with Redditch, especially some of the more deprived areas, because that is a real pattern in our data. Everywhere's significantly better than average on mental well-being, except for Redditch and on the anxiety measure.
Thank you very much indeed. I've got the last two questioners, Councillor McSweeney and Councillor Eacock, please.
Thank you, Sharon. Thank you, everybody. I will try and be brief. I just wanted to say, just to start, thank you for the work on vaccinations. I was very happy to bring this up at full council, and as I say, that we're doing what we need to do better. I'll move on. I wanted to talk about the physical activity. I noticed sort of mention of physical activity for children, which I'm going to ask a specific question on, which is that's the again we come back to Redditch, where it's there is more to do in Redditch. You're talking here about sort of what we're doing. My question is about, do we have an idea of the cause? Why Redditch is an outlier here? A more general question in terms of sort of just looking at adults. There's sort of bit about here about Healthy Worcestershire. It's just sort of like, I mean, I say it's kind of one of my pet subjects. I think I kind of have sort of said hello to Claire this morning in this meeting, who I know from a different WCC, Worcestershire Canoe Club, and I'm sort of very much an advocate of sort of physical activity and sort of like in terms of sort of like the benefit, I would say hugely to mental health well-being. I mean, I've also recently started a new job where I'm actually working with sort of some children who have difficult lives and seeing the effect of their mental health, improvements of their mental health. But I should say I'm working as a climbing instructor, so this is a very physical thing, but you see the sort of the benefits to mental health. So just in general terms, what are we doing? What more specifics on what there is in terms of that? Is there sort of like grants and things like that in terms of getting sports? So the final thing, I'm not expecting an answer on this. I feel I do need to raise this point. One of my pet subjects in terms of, it comments here on paragraph 53 about physical, mental and social well-being in an integrated manner. I want to sort of just raise the integration of also into sort of the transport in terms of looking at actually enabling active travel, and there's integration. So I'm not expecting an answer. So obviously it's wider than this, but just to encourage the working across different things in that direction. Thank you.
Thank you very much. I don't think he's anticipating an answer, so maybe have a conversation with the team outside. Thank you very much. Councillor Eacock, please.
Thank you, Chair, and thank you, Lisa, for all your hard work, especially helping me with adult social care. My concern is also about Redditch. In the report, it says physical activities in schools has decreased in Redditch. Are there any specific reasons, as more parts of Redditch are now classed as deprived? Redditch has declined by 47.9 to 42.36. That's a big decrease. Living in Redditch with small great-grandchildren in school or starting schools in the near future, it's a concern to family members. So it's very good to hear all the work being done in Redditch, and that is going on in the schools to try and prevent things like smoking
and vaping. You have also named Woodrow and Winyates in the report. Are these the only two areas in Redditch that are going to benefit from the grants allocated? And how or when will the voluntary sector partners start, or have they started? Will this also include the dangers of smoking and vaping, as well as physical exercise that needs to be back in our schools? Thank you.
Thanks, Councillor Eacock. As you all know now, we've got a real focus on Redditch because the need there is greatest. And so, yes, we do focus on particular neighbourhoods like Woodrow, and we address all of those things that you mentioned, including a lot more. We're just as interested in public health and crime prevention and helping to prevent young people getting drawn into crime as we are health. We have a big focus on physical activity. We've just enabled through our grant programme the opening up of a new hub, which is being run by Pete Martin, who is an absolute legend, multiple black belt, but also brilliant at engaging young people and getting them out of harm's way and into a healthier life through physical activity and other means. So there's an awful lot of work going on Redditch. I think some are structural as well. Transport, for example, is not necessarily something public health can do much about except constantly moan about it, which I do and will. But yeah, there needs to be a big focus on Redditch. We're not only focusing on Redditch, though. I wouldn't want anyone to sit there thinking, what about my area? We have 14 priority neighbourhoods that we focus on. But Redditch does, as per the data, have a high level of need. I've got Elizabeth waving at me, so...
Hello. So in terms of physical activity, Redditch has actually got a Movement for Change partnership up and running, so trying to pull together many third sector organisations with the district councils, with people that are interested in promoting physical activity in their area. And through that, I've been able to identify a particular person that we could just give additional funding to be able to deliver more Couch to 5K programmes across different areas. But I suppose I just did want to come back to the point that was made earlier about physical activity, because it's almost our way of improving health by stealth. It's our route into indirectly improve a number of health measures. And so in public health, we take that kind of structurally. So what infrastructure have we got, and where we can, are we able to put in some new equipment in different areas to enable physical activities? We've also got events, so things like the Withel Fun Run, but also including the family element of that. Junior Park Run, we've enabled some of those to run. We've improved paths so that we can have park run and park yoga and things going on, as well as training people up for sustainability as walk leaders, as run leaders, to be able to keep those things going beyond the grants that we're able to give. And in addition, we've got things like leisure vouchers that we can put into really deprived areas. So really trying to remove barriers to access as best we can, and our grant programme's been really excellent at that.
That's a wonderful way to end this section, barriers to progress, because that's what you try to do, remove those barriers and enable. I thank you all most sincerely for your attendance this morning and your contributions, and thank you for all the work that you're doing. I think we'll have a discussion as a board afterwards around poverty and child poverty and health inequalities, and any specific piece of work we can do to enable you to progress in those areas. But thank you. Thanks so much. Great to see you all. Thank you. We will be changing over in 2 seconds to Vivek. Thank you. We'll just wait for the public health team to leave the room, and we'll invite you to come forward, Vivek. Have we got a nameplate, please, for Vivek?
He's got it.
Oh, you got it with you, thank you. Thank you so much. I'd like to welcome Vivek Cashew, the Director of Strategy and Engagement from West Midlands Ambulance Service here this morning. Thank you for your time and thanks for your patience while we discussed the public health review. Vivek, can I hand over to you to take us through the papers that you've provided? Thank you.
Thank you, Councillor May. I mean, it's very interesting for me to hear the first part of the meeting. I lost my dad to lung cancer. He was a smoker. So very pleased to hear about all the efforts to take out smoking as a dreadful habit. But on to more positive, so let's get on to a more positive topic, the ambulance service. So a year goes very quickly, doesn't it? Because I was actually sat here literally about this time a year ago. Time does fly. At that last meeting, I was able to report a substantial increase in our performance and much better response times. I'm also pleased to be able to say here today we've largely sustained that performance. It wasn't just like a flash in the pan. We have sustained the performance, particularly around what we refer to as our Category 2 response time. So those are the response times we're measured on. It's about half, nearly 2/3 of our workload. There's 4 categories. Category 1 is people sort of dead, dying, cardiac arrest, fitting baby. Actually, thankfully, a small proportion of the work we do, less than 10%, maybe 7 or 6%. The Category 2 workload is the bulk of what we do, which is chest pain, shortness of breath, stroke-like symptoms, bleeding. That's actually the bulk of our workload. So the standard at the moment is 30 minutes. That's what we're measured against. Year to date, we're at 25. Earlier in the year, during summer, we're at 21. So winter has been challenging because you can see how we've eroded somewhat. The actual original standard was 18 minutes. So we're not. The country is not measuring itself to what it used to perform at. The standard was reset to 30, and we're well below that. Not every ambulance service is. We're one of the few that are. We're really pleased about that, of course. I guess I just touched on winter. Winter's been challenging, so quarter to date. So I guess if we take in the winter period, it's at 29 minutes and 8 seconds. So still below the standard, but not good enough for us. We want it clearly to be better than that. At the last HOSC, I referred to some significant actions we took to restore performance, which is largely around a substantial increase in our resources, our frontline resources. That amounted to about £30 million worth. So what does that mean? Well, it was about taking our kind of daily peak resourcing levels across the region from around about 350 ambulances to around 410. Why did we do that? Well, I'll come on to it in a moment. Our resources, the hours of ambulance time out there and hospital handover delays are still a major, unfortunately, still a major issue to us locally here, but in the region as well. And I'll come on to more detail around that. So that was us saying, well, if up to 1/3 of our resources are locked up, the only thing we realistically can do is to backfill that. I'm not saying it's a good use of resources by any means, because there's clearly resources already out there, but patients need response. When people ring 999, they need an ambulance, and we need to be able to meet patients' needs. So just talking on the handover delays, just some detail around that. So we've just finished January recently, haven't we? That was our second worst month on handover delays. We look at Herefordshire and Worcestershire together, so just forgive me if I talk about Herefordshire and Worcestershire as a conglomerate, so to speak. It was its worst month for handover delays. So we lost 50,000 hours in January. I've just had the figures come in while we're in the meeting, actually. I'll just give you some comparison, because you think, well, what does that mean? How does that compare? So we lost 50,043 hours in January. The next highest loss of an ambulance. So there's 10 ambulance trusts in the country. So the next loss was 27,000. So you can see how much of an outlier we are. The next below that was 26, 19, 18, 12, 5, 4, 3, 3. And then Isle of Wight, it's an ambulance service, but let's just discount that. So we are a huge outlier in the country, actually. And in other hospitals, I've had to say we are, as far as lost hours to handover delays go, it is the worst by far in the country, in the West Midlands. Herefordshire and Worcestershire, so I've given those are figures for us as a regional ambulance service. In January, it was 6,500 in Herefordshire and Worcestershire. You can see some of the highest performing ambulance services have less than that across their whole footprint, not just within an individual system. The totality of this, I think I mentioned before, it's about a third of our resources. Now, of course, if I came to Worcestershire County Council and said, I'm going to take a third of your social workers away from you, they're going to work for us now, how could I expect you to discharge your duties without some significant, we couldn't, could you? Just like we couldn't, and that's why we had to take the action that we did. So some of the things going on, just in terms of the paper, you'll see one of the only things our partners ask of us is to make sure we get patients into the right place and don't just sort of funnel everybody into a hospital and into an emergency department. And I'm pleased to report we're doing really well in that regard. So our conveyance rates to hospital are below 50%. So of the workload we get, we only take about half to hospital. We have the best, what we refer to as hear and treat. So when you call 999, and we can actually sort you out without an ambulance because we can refer you to, for example, community-based services. That's the best in the country. We do about 20 to 25% of our workload just like that, actually. The paper also illustrates demand isn't a problem because if I was talking about rising handover delays, but actually just more and more patients going into hospital, you think, well, hang on a minute, we need to think about how we're handling this workload. You'll see in the paper demand isn't actually ambulance demand, sorry, I should caveat that ambulance demand isn't the problem. And nor do the handover delays have a relationship to demand, actually. So it's not just more patients equals more delays. There's something else going on in the urgent and emergency care system. There's two, I guess, principal actions that have happened or are about to happen. So we've talked about our resourcing levels. We don't want to sustain them in the way that we have like that. We want our existing resources back. And why is that? Well, it's important to us as we're all taxpayers, aren't we? We need to make best use of our resources. But actually, fundamentally more important than that is for our staff, it means getting off a shift on time. It means them seeing more patients. So pre-pandemic, our staff would do around about 7 cases on a 12-hour shift. That's probably around about 3 at the minute. And if their first case takes them to a hospital, it could be the only thing they do, 1. That's not a great use of our resources at all. So that's why we want to reverse our way out of all of that. But so the things we're focusing on are the continued effort around non-conveyance, or what we refer to as non-conveyance. So not taking patients to hospital, but getting their needs met through other means. That's something we remain focused on and have made some really good progress in. And then we'll come on to talk about a maximum wait. So NHS policy last financial year in this current year is that no ambulance should wait more than 45 minutes, and the actual routine waiting time should be more like 15. That's clearly not the case here. It's not the case largely anywhere other than most of the time actually in South Warwickshire, in this part of the world. Today, as it happens, Worcestershire Acute are going live with a maximum wait protocol. It starts today, actually. So the regional team, so NHS England, have convened the most challenged organisations with us. So Staffordshire, Shropshire, Worcestershire, Dudley, Birmingham, Wolverhampton, there's a growing list, to work with us directly on implementing a maximum wait. It's already in place in a number of other parts of the country, so London. So London Ambulance Service, for example, is a busier ambulance service than we are. Their waits, their lost hours was something like 11,000, I think I quoted something like that order. We had 50. South West Ambulance Service used to be the service with the longest, with the greatest amount of lost hours. The South West has implemented a maximum wait protocol across all of its hospitals. Now, their delays, they've been higher in January, but have been as low as 7,000 and 8,000 and 9,000. So the regional team here, the NHS England regional team, clearly want to get that in place in here for all the right reasons. As I say, Worcestershire Acute are going live today, started this morning. What it looks like, there's a graduated, because to go from having, so last week we had patients waiting 7 and 8 hours to be handed over. It's unrealistic to think, well, next week they're going to wait no more than 45 minutes. There's clearly a lead into taking such substantial action. So week 1, so today, week 1, no patient will wait more than 4 hours, is the commitment the organisation and its partners are giving. Week 2 will be 3 hours, week 3 will be 2, week 4 will be 45 minutes. So basically a kind of a cruise into a maximum wait of 45 minutes. That's only during the hours 8 till 6, effectively during kind of core kind of opening hours, so to speak. Clearly they're open overnight and everything else. Whilst, you know, I saw your expression there, Councillor May, we kind of feel the same way too, but when things have been so bad for so long and the start point is so far, is somewhat behind us, there does need to be a credible lead in time, and we respect that too from Worcestershire Acute and their partners. It's not going to just change overnight. There's actually a really big kind of organisational hearts and minds piece to all of this about a culture and a behaviour, about how do we restore something we've not had in place for years, ultimately, because I've been coming here for years and we've been having similar discussions about this topic, haven't we? So that's kind of news today. We'll have to see how that goes, and no doubt you guys will be pulling other parts of the system in to discuss that progress, and you know, you can bring us along with them so we can all talk about how that's gone. We wouldn't mind that. I guess the last point I would just refer to, my paper talks about the patient safety element. Well, clearly better response times equals safer care. So we're in a better place than we were a couple of years ago. We want to be doing better still. The original standard's 18 minutes. Whilst we're meeting kind of government standard, you know, one way that's good. It's not, as I say, good enough for us. And as I said earlier in the year, it was better. So I was able to report better performance than I am. So, okay, great, we're meeting our standard, but we were doing better and we want to do better. I'll perhaps pause there and take questions from the committee, if I may.
Thank you so much, Vivek, for taking us through the papers. And first of all, my condolences on the loss of your father. I'm very sorry to hear that. In terms of this new approach that's been taken, and I've had an indication from Simon from Health Watch, he'd like to speak in a moment, but I don't understand how, I'd like to see flash to bang, but in the real world, how does this happen? You know, how can you just keep taking an hour off the waiting time? Where are these patients going? How's this going to pan out, please?
Sorry, I switched on a bit too soon. So hospitals have adopted it there's not like a set sort of formula. People have done it in their own way, but essentially this isn't about just piling in more patients into the emergency department. That is not what it's about, because that, whilst it may help us, it doesn't help the emergency department, and that does feel like a little bit of a nil or draw actually, in kind of, if we were to talk about football parlance. So that's about it. The places that have implemented it effectively have actually managed to reduce their occupancy in the emergency departments when they've done this, because they've asked more of everybody. So, for example, last week Birmingham went live, the UHB group went live. The handover delays, particularly on the Birmingham Heartland site, have been radically improved. How have they done that? Well, I guess over months and years, you tolerate inefficiency and you tolerate time being wasted, and we all get kind of used to it because it's just the way it is around us. So, for example, now if a patient has their transport booked for discharge, they will receive their next patient. What would have normally happened is patient will have their ward round takes place, transport booked, that might come some hours later, patient stays in their bed, patient then goes, some hours later maybe the site team gets informed of a bed being available, so you could go for many hours with that bed being available, so to speak, but not actually being available. So they've forensically gone through all these sorts of processes and are eliminating those sorts of things. Now, it's only been a week, but I have to say, we used to have 30 ambulances, 20 ambulances waiting outside that hospital. It's not the case. It's just not happening anymore there. It's been a week though, touch wood. So basically, it's asking more of everybody, and what people are finding is when they're put under a bit more pressure, they find a bit more efficiency in how they're working, because they don't wish to just take more patients. They need to find a way of doing that in a more sustainable manner. The bit where I guess it gets a bit more difficult, though, is it can't be just the hospital shouldering this kind of pressure. You know, partners in terms of community care need to also shoulder that burden too. So I guess what we've had is a system where the ambulance service and the emergency departments have been the primary risk holders when it comes to patients. That's now being pushed all the way through. It's been distributed out in a more manageable and sustainable way. But as I say, the immediate fear is, do we just push patients into emergency departments and like walk away? No, we don't. We've never done that. We wouldn't do that. But the hospital and wider healthcare system are creating a flow that was never present before to get patients pulled out from them. And as I say, another organisation, Leicester. So Leicester, perhaps the busiest single ED in Europe, potentially. Sometimes will do over 1,000 patients a day. They've reduced the occupancy in their ED because everybody else is essentially pulling their weight with it. Now Leicester is like a beacon site for this process, and Leicester has been supporting Worcestershire Acute with how they've gone about doing it. They're supporting a number of other hospitals in terms of cross-fertilisation of learning and how they've gone about sustaining it.
I'd be interested in an update on this actually in the forthcoming months, because I really am. It's a wonderful target, but in reality, I think the constraints you faced over the winter period in particular will still be there going forward. And when we talk about the wider system, how have we imparted that information? And has it been a cascading effect? And are they aware? Are our partners across the health economy aware that we've gone live today with this, please?
So I've had there's quite a substantial communications package that's been aligned to all of this. I mean, I've got it in front of, it's in my inbox now, it's just been sent to me, but so that this has been primarily directed at the ambulance service and the acute trust, and then we have then been liaising with our partners that we need to work with. So Worcestershire Acute been working very closely with Worcester Health and Care in this context, as other trusts have done with their partners too, because as I said, this can't be just shouldered by an acute hospital. It's too much. Everybody needs to do their bit to contribute. So Worcester Health and Care are engaged. They have been engaged. They have been working with Worcestershire Acute hospitals. So whilst NHS England have primarily directed the kind of focus upon us and the acute hospitals, we then have gone away to work with the partners we need to work with.
Thank you very much indeed, Vivek, for that. I'll start with Simon from Health Watch because he raised his hand first of all, then I'll come to Councillor Oodle.
What I was going to say, I think Vivek is... sorry, good morning. I'm Simon Adams, for those of you who don't know me from Health Watch. I'm the chair there. And I've been around this problem now for, goodness knows, Vivek, 10 years, 12 years, 13 years, I think. And I have to... Thank you. and I have... The Boer War, did you say? and I have to say, you know, some of our practices, and I think reflect on that. But I have to say, you're saying, you know, I think it's widely accepted, and I should also say that our colleague, Chris Byrne, who sits on the Urgent and Emergency Care Board, couldn't be here today because he's on holiday, so therefore he might be more up to date with some of these developments. But I think Vivek has put his finger on it, that it's been a long-held view, I know at Worcestershire Acute, that actually it's not essentially an ED problem. It is about the way in which the hospital actually functions and operates. And then you get into flow and getting patients out of the hospital into other areas. And of course, I guess HOSC knows there is a project ongoing at the moment to look at Transform, and was about to start looking at the use of our community hospital beds. And I assume HOSC will take a close look at that as a big change for Worcestershire, I think, in the way those beds are used. But, you know, so Vivek has covered off some of the issues, because the last thing we want to see is it's a 45 minutes to release the ambulance rather than it's 45 minutes to actually get a patient into hospital and the patient being properly cared for. Because I was talking to a carer only yesterday whose father had spent about 8 hours on an ambulance, right? I was actually saying to the carer, he's probably better off in that ambulance and being better cared for than there would be in a corridor in the hospital's ED. So that's would be our concern, is that offloading patients, they're actually properly dealt with and not effectively stacked in corridors to release ambulances. And I think you've started to touch on that Vivek, so I won't push on that. What I would say is that I think it's next month, isn't it, that we're planning to go into the hospital to talk to patients in the ED department. So we should manage to be able to come back to you with some feedback later on in the early summer, with some feedback from patients about what they think of the arrangements that are going on there, which won't necessarily, obviously, they won't be aware of the 45-minute release of ambulances.
Thank you very much.
If that helps.
Yeah,
Chair.
it does help. Thank you very much. And I was aware of what's happening with the community hospitals, but it is on the work programme to look at as well. But absolutely would welcome any feedback, please. Vivek.
Just, I guess, a couple of reflections on the comments there. So we will not, and our staff wouldn't just push a patient into a hospital and walk away. That would not be the right thing to do, and we would never support that. However, there is going to be a sharper bit of a pointy elbow end to this, which is our staff have got to be empowered to walk away once that maximum weight has been reached, because otherwise this doesn't mean anything, actually. So that's not something we've enforced or we've pushed for, actually. That's where a hospital has naturally got to get to a place where it can be comfortable, because it's got the right kind of processes in place that it can enable our staff to go. So we're never going to ask our staff just to walk away from a patient, and they wouldn't do that either. We wouldn't ask and they wouldn't do it. But we are going to have to get to a place where actually our staff are empowered to leave by the hospital, because the processes are there to enable that to happen, is one thing. I will pick you up on the comment about, is a patient better off in the back of an ambulance than in the corridor, though? Well, people may say yes, but what about the patient who doesn't get the ambulance, actually? Because whilst the hospital's taking the ambulance and the patient's in the back of one, having 2 staff members looking after them, which is great for them, the patient who's called 999 is stuck on the floor or is dying, gets nothing. So if our ambulances are being used as majors cubicles outside a hospital, who else is going to go to these patients then, is the response I'd give back.
Thank you very much. A really pertinent point.
Yeah, can I just come back on that? Because first of all, I mean, I would say, I wanted to say, and I'll say it now rather than say it later on in the discussion, at one time, we were, the constant refrain from patients was the ambulance has never turned up or it's taking forever to get there. That has dramatically changed, right? So I would give you that feedback. The other thing is you were making your point to us how well you were performing in response times. So even though your ambulances are queued up and you've got this tremendous demand on your time is 50,000 hours, you're still managing to hit your response times. So if you do manage to release your staff within 45 minutes, one assumes that your performance on your response times will accelerate exponentially. Or you're going to take that staff out, the resource out.
So we want to get to 18 minutes, which is the original standard, and which is what the NHS originally had. But I also said that we're achieving it kind of in an unsustainable way with resources that aren't actually really even available to the NHS. So actually better using our resources. So if we could, who could take out 20 million plus of cost and not have any detriment to their performance? That's the kind of win we could have here, actually. So we don't have this amount of money in our budget. We've had to have a really difficult, long-winded negotiation and mediation with our commissioners to get people to account for the fact that, well, we don't have our resources, so somebody needs to pay for this. It's not been easy. So where we'll ultimately end up with it is sustaining or improving our performance at lower cost, which is like the holy grail at the minute for all of us in public service, isn't it?
Thank you very much. Councillor Oodle, please.
Yeah, thank you. When I knew you were coming, I decided to ask you a question on a subject which, strange enough, got some publicity yesterday, which is the issue of sepsis. Sorry? Okay. As a sepsis survivor myself, somebody who spent a lot of time in hospital waiting for treatment to gain the initial antibiotics, I was a bit alarmed to hear that only the Isle of Wight and Scotland have sepsis training for their ambulance and paramedic crews, and only the Isle of Wight and Scotland have intravenous antibiotics on ambulances. Is that likely to be changing in West Midlands? Is it something which we can look forward to? Because clearly it's an issue, especially despite what we've said, the long waits will continue for some time to come, and somebody with sepsis could easily die waiting.
you're taking me a little bit out of my own subject area, I guess. So I need to follow up on that question and come back to the panel if that's okay.
Absolutely,
if you just
perfectly
let me
acceptable.
Make a note of.
Thank you, Vivek. Thank you. Good question, though, because sepsis is a very important matter that needs to be addressed as quickly as possible, as we know. Councillor Fordington, please.
Just looking at patient safety, it says handover delay. So that means the first part of delay. Then response time, another delay. Patient safety, another delay. So it says it's strongly linked to one another. So there's got to be something which needs to be solved and something needs to be put right. I've actually been in hospital where I injured my back. Anyway, what happened was that when I injured my back, I was in hospital. I was in the ambulance first, and then I was moved into the A&E sort of area, but I was moved into the corridor. Anyway, I was in this tremendous amount of pain. Anyhow, what happened was I was just pushed into a corner and I was left unattended. Another doctor came along, took my gas and air away from me. And I was screaming with pain and I was wanting to go back to London because that's where I was originally from. And I was thinking to myself at that point, I was better off having had this procedure where I had had a nasty fall to be in London because I would have been treated quicker. But going back to what I've sort of said, these delays, this pushing the can sort of situation needs to be put together and organised really quickly.
I don't know if there's a question. I guess it's a comment, really. I would agree. We've talked about there's essentially a lot of wasted time, isn't there? And it's patients' time and it's our staff's time added together. We've solved part of it, which is the response time element. But it's all well and good to get your ambulance, which obviously is good. But to then sit outside for hours upon hours upon hours, do you get assessed quickly? Does a doctor come and then review you quickly? Do you get all your investigations and treatments initiated? Well, not really in the back of an ambulance. So whilst we got the first bit of this sorted out, well, actually the rest of it is still needing major recovery, isn't it? And I guess that's where this maximum weight process is meant to come in, because it's not really intended to just, as I say, just bring people in and chuck them into a corridor. It's very much about getting patients handed over and getting the care initiated. And as I said, the experience of those who've done it well has actually been to reduce the occupancy levels of their emergency departments, which is clearly of a benefit then to the next patient who needs to be in there.
Thank you very much, Vivek. Councillor McSweeney, please.
Yeah, thank you, Chair, and thank you for coming and talking to us today. My apologies, I'm just picking a little bit on detail here. You said in your presentation that January was the second worst in terms of hospital handover delays. I mean, I've got figure 2 in front of me from the paper where there are 3 months which are worse, but obviously you were talking about second worst in terms of the ambulance service as a whole for West Midlands, and this figure, I'm assuming from what you said 6,500 for Hereford and Worcester, which is the figure we've got here for January. So this is Hereford and Worcester. So obviously, anyway, to come on to the point, so second worst for the ambulance service as a whole, it's only the 4th worst for Hereford and Worcester. So the question is it not going quite so badly here, or are we just talking statistical anomalies?
So if I test my memory, the highest perform. So we've got 6 kind of areas of our ambulance service. The best performing. So when I'm talking about kind of like ICB footprints, if we think of it like that. So the 6,500 or so relates to Herefordshire and Worcestershire. The highest performing, so to speak, was Coventry and Warwickshire, around about 4,500 off the top of my head. I could be wrong, give or take. But as I said, South West have managed to get down to, say, 7,000 for their whole region. There's ambulance services in January done 3,000 or 4,000 for the whole region. So I guess the point I'm drawing out here is Herefordshire and Worcestershire have had more delays than other whole ambulance services. Now the thing is, in the context of the West Midlands, it's not the worst. It is worse elsewhere, as you might expect. With much bigger population bases in some places like Birmingham, Black Country and so on. But even so, it's still a large figure for the population here. And actually, whilst I may say that, if the leadership of my rest of my colleagues were here, they'd be the first to say that too. They would absolutely acknowledge it as well. It's not just me. I don't have to speak on their behalf, but I know they would agree with me and accept that too.
Thank you. I think the point is Worcestershire's 610,000 population, Herefordshire, about 180,000. If you look at that and compare that to the Black Country in Birmingham, our population size is much smaller, but our waiting time clearly is just not where it should be. I've got Councillor Jenkins next, please.
Thank you, Chair, and thanks, Vivek, for this. A couple of points. One, just following up on this max weight protocol thing, because from your description of it, it kind of sounds like good practice, best practice. This is what we should always be doing. So kind of initial thought was, why aren't we just always doing this? Why does it have to be suddenly brought in that we should be a bit more efficient? So first, just answer that for me, please.
Here's a really good question, because, I'm not sure why it's taken this long. Because London Ambulance Service actually pioneered this now more than 2 years ago as a process. I think in some respects we've been a bit of a victim of the response time equation here, because our response times, other than a couple of years ago now, people think, well, the response times are kind of okay, but actually they wouldn't, if we didn't do what we did, they would not be okay. We'd be having a very different conversation here had we not put in the resources we had. We'd be talking about some really awful patient safety incidents and experience. We'd be talking about dreadful experience for our staff. We'd be having a very different conversation in this room. So I think it's partly been about, well, we've managed to sustain response time, so kind of solved some of this. I guess the other thing, though, because other organisations have managed to tackle it, I guess we're last in line on the bus, on the on the line of stops, and the focus has nationally come onto this region about, oh, hang on a minute, what's going on over there? It has attracted national attention, as it should do. It's also now attracted regional attention, as it obviously ought to. And, there's as I say, we're in a weekly meeting, those organisations and I, with NHS England every week, where NHS England say to each of the trusts, and it's with the exec teams of each organisation, now talk us through the next stage in your plan to implement this. Right, next trust, your plan to implement, and that's the kind of conversation that we are now having. I guess I could say better late than never, but we are last in line, in some respects, to have it implemented.
Thank you very much indeed. Did you have a supplementary?
Yeah, well, it's kind of a second question, but it was kind of very much related to that, because it sounds like your good response time has been kind of masking the issue of the problem. And you, I think, refer to paragraph 18, or I think it says that you kind of say the issue is emergency department waits. So it's kind of like you're kind of covering, by having more ambulances, you're kind of managing the issue that there's this blockage at emergency department. So you kind of, it sounds like we're spending the money in the wrong place, spending it on ambulances, where we should be sorting out the issue in the hospital, which is kind of what you're saying. But I think it's. I mean, you're here to represent the ambulances, not the hospital as such. But it sounds like maybe this kind of max weight protocol thing is a better way of fixing the problem, rather than just kind of keeping adding more and more ambulances to try and kind of mask the fact that yours isn't the issue. You're doing fine to some extent.
So we would agree, we don't want to keep putting more and more ambulances out there. It's not a sustainable model. What I would also say, I mean, my background has been in hospitals. My background has been in, hands-on operational leadership in acute hospitals. The core problem here and elsewhere is not how many patients are turning up, and we always talk a lot about demand side and activity and how many patients came that one day and things like that. It's about how many patients are waiting how long for beds in an emergency department. That is where this is all stemming from. So every day, how many patients are waiting how long for their beds to be admitted? Because other patients who could be spending 1 day, 2 days, 3 days in a cubicle in an emergency department. Clearly, they've only got so many of them. So that is actually the nub of all of this. It's a length of stay and occupancy issue, not a demand one or other things. I think that's the primary issue.
Thank you very much. So our future agenda items on patient flow should be very interesting, shouldn't they? With the outcomes when we question the Worcester Acute Hospital Trust. Okay, thank you for that, Councillor Jenkins. Councillor Turner, please.
Yes, thank you, Chair. 2 questions, really. The first one is very much in connection with what we've just been talking about, and that's in regard to response times. I was just wondering if that had anything to do with the geographical setup of the county that we're in. Obviously, we mentioned London before. Obviously, just close proximity to the patient may be obviously easier to obtain rather than if it's way out in the countryside. So a geographical implication there. And you'll have to forgive me with your presentation when you first started, you used some terminology. Not all patients would probably refer to hospital. And I just wondered how would those be dealt with? They dealt with by the patient calling 999 and then ultimately be referred to maybe a 111 service rather than actually sending an ambulance out, or would probably a paramedic would treat the patient at their home.
So I guess two questions there. So rural versus urban response times. Urban response times are quicker for sure. Just linked to that though, one thing it'd be something the HOS could actually help us with if I could take the liberty of asking for something. We have wanted to do an independent capacity review of how much of what do we need and where, because actually this model that we've got into of just putting in more staff behind it, we need to get into a sustainable model. So, and we wanted to do that not just at a region wide, because actually we're only measured as an ambulance service at a region, but we wanted to then do that by kind of geographical footprint and almost down to a postcode actually, to give people the kind of sense of what would it take to provide the level of response times almost to a particular kind of locality. Your second point then about how do we manage the, sorry, just on that previous one, we would like the support of the HOSTAT to do that, because so far it's not been supported by our commissioners, but we think it would be a very valid exercise to do.
Right, Vivek. Happy to look at this, of course, but we'd probably need some more information about what your expectations are from our perspective. So we'll take that offline and absolutely look at it. Thank you.
I'd appreciate that. Thank you. Then the point about how do we do non-conveyance? So it's threefold really. So if you were to call 999, the first question you get asked is the patient breathing? Because it's meant to be an emergency response to really sick people, clearly. Now, obviously, a fraction of what we deal with is actually that kind of patient, and in some ways a good thing. We clearly don't want everybody to be like that. Now, what we've got then are lots of categories of. So this is it's an algorithm we follow. It's not individuals making up their own. It's not their own interpretation. They're not allowed to have an interpretation of it. It's an algorithm. The algorithm will then say, well, actually, this patient can go into what we call a validation pool. And so we've got 24/7, a whole room full of senior paramedics and nurses who will receive that patient and then call you. And so you've called 999, talk me through your problem. And it could be, typically it could be somebody or on your behalf or you saying, I don't know, I've had a fall, I can't get back up off the floor, my hip's is really in pain. Now, we might then say, well, actually, you might not need a blue light ambulance. We'll send urgent community response to come and see you. We don't have to pick up a phone and have a conversation. We refer electronically. We'll send an electronic referral over to the single point of access here, and you'll get urgent community response coming out to you. So it's quite actually a fairly slick process. We're not having to make millions of phone calls to do referrals. These are electronically done on a system, and then the patients are taken off our hands. While I was just listening to the public health talk, just on this topic, so we will refer 50 to 70 patients a day in Herefordshire and Worcestershire on that basis. They'll take 20 to 30 off our hands. Now, before we did this, all of those patients would have had an ambulance. And then the ambulance would have maybe called a single point of access to say, look, actually, I don't think we need to take this patient to hospital, but we think you guys could come and help. So it's a much more efficient way of trying to deal with workload. And as I say, whilst we are an emergency service, we do have blue lights. Actually, a lot of the workload we deal with is urgent rather than true emergency.
Vivek, do you have an interface as an ambulance service with the virtual ward as well?
Not directly to virtual ward. So if we have a patient that we think could benefit from the virtual ward, we can refer to it and somebody will make that decision. The other thing we've got that we've put in place in January is something called call before you convey. So there are some predetermined pathways where it's just obvious you've got to go to hospital and there's no point ringing anybody, and they're excluded from this process. But for everybody else, we ask our staff to put a call in first. Now the call might just say, you know, bring them to hospital, don't worry about it. Or it might say virtual ward, it might say go to surgical SDEC, it might say, you know what, keep the patient at home, we're going to send somebody over there. It might say all sorts of things. So we ask our staff to do that for us. Now, again, just some numbers for HOSC members. We used to do that pre-January, we used to do about 50 a week, give or take. It's not many really in the context of the workload. That's more like 250 to 300 calls a week now going through. Our staff, it's not universally popular with our staff, I have to say, being very frank, because our staff might say it takes away clinical autonomy, you know, we don't need to call, but actually our staff aren't aware of everything that's available out there. How could they be? There's so much going on in terms of services. So actually this is a supportive, it's intended to be purely supportive, where you can discuss your case and somebody will say, take them or leave them or take them to such and such place. It's not absolutely not there to intended to undermine anybody. It's very much a supportive mechanism. And what this is highlighting, because some of this is about busting myths actually. So a lot of people would say, oh, if only you called through all of these patients, we get too many patients who shouldn't be coming. If you called them all through, we wouldn't have this problem. So people need to be careful for what they wish for, because it's now happening. And what it's highlighting actually is gaps in services and issues where actually things need to be resolved, which is fine by us, because people can see, well, with this workload, if we had this service in, we could prevent them the need to do X, Y, and Z with them. So it's highlighting gaps in services and kind of areas which could be better served. So it's a good thing, but it's quite new. January, we really went for it in a big way.
Thank you very much indeed. Councillor Turner, has that concluded your questions? Yes, thank you. Thank you very much. Councillor Kumar, please.
Thank you, Vivek, for that excellent presentation. As usual, we appreciate the hard work the ambulance does and never gets a kudos for all the good work they do. I just got a couple of points here. After your Care Quality Commission review last year, just need to ask, have you noticed any noticeable change in clinical outcomes for patients and their satisfaction levels? Because last year we had a different patient satisfaction. So that's the first question. And the second one is, you had a £23 million settlement. And then how is this funding being used to improve the conditions? And some of this may be to do with the hours you talked about, but are there any other things which they are being used for better use? Thank you.
So on the patient satisfaction stuff, perhaps I'll send some numbers through around incidents and things like that, so patient experience outcomes. But there are an absolutely very clear and obvious correlation between response times and things like serious incidents, deaths, untoward harm, and that kind of thing. I'll send you perhaps a small table of, say, month on month, year on year, what's going on, because you'll see the relationship to that. The other thing, we haven't touched on it, but I guess it's a factor of life. The one thing that has also been rising, if we're talking about satisfaction experience, is violence and aggression and abuse towards our staff. A sad reality, but that's also been on the rise. Now, we did think, well, if we were providing a better response, maybe some of this might go, because inevitably patients get frustrated, angry, upset if they're not getting the response they need, but it hasn't been quite the case, actually. So there's maybe more to it than maybe just response times. On the 23 million settlement, the bulk of that has gone into frontline resourcing. We have put some resources also into that clinical validation team that we were talking about, and also into our call taking, because the other thing I perhaps should have put in my paper, our average call pickup time is 0.01 seconds. It's instant. So the ambulance service gets measured, and the first safety net is getting your call answered, because no one does anything until your call's picked up. There are other organisations, so we get measured at how many patients wait 2 minutes or more for their 999 call to be picked up. We might have 1, 2 or 3 who've waited 2 minutes. There are other organisations who could have hundreds, thousands even. So our call answer, if anybody called 999 to us right now, you would have an instant call pickup. But I'll send through I know that it's followed a trend. I'll give you some actual numbers so you can be assured properly.
Thank you very much indeed. Councillor Wells, please.
Chairman, thank you. I don't know if I'm the only one in the room, but I do enjoy watching my Saturday night TV, and the dramatisation for purposes of entertainment of the performance of the ambulance service. Now, I don't know how much of that is fact and how much is reality. That's probably a discussion for another day. But it does bring me to thinking about the key components in all of this. There are so many things out of your control, but some things that are within your control. And one is the way you identify the categorization of calls as they come in. And clearly that's a crucial part of the process, that telephonist responding, is this category 1, 2, 3, or 4? What work goes on to ensure that that process has the integrity and the professionalism that it needs to make instant judgments about what actually patient circumstances are? So how do you monitor that? How do you ensure that that is working as well as it possibly could? And are you aware of sometimes where there have been mistakes?
So the algorithm that's used is called NHS Pathways. It's a nationally determined algorithm. It's not one we've sourced locally or developed locally. It's one that around about half of ambulance services use. There's another system that the other guys use. So first of all, it's not anybody's kind of judgment, so to speak. It's an algorithm that they follow, and it tells them what questions, and they ask the questions. It's no kind of local knowledge, so to speak. It's not someone's own opinion. It's very much like that. Is it perfect? No, it's not still, because actually what I would say is that too many patients are categorized into category 2. We could perhaps have more that were actually in category 3. It's a very blunt, but inherently it has to be blunt, because what we don't want to do is have a sick patient who's under-categorized, so to speak. So it's very risk-adverse, which is why so many patients are put into the higher tiers of call categorization. In terms of the assurance behind the quality of the call and the quality of it, there's a significant audit program that goes behind all of the call taking. So all of our call assessors are subject to audit. All of them have audit undertaken on the quality of their calls, and they get measured in terms of a percentage score. And that's on a rolling basis, so nobody gets to evade it or not experience it. It's part and parcel of their life. Their quality of their calls that they undertake are audited against criteria to make sure they are undertaking the call according to the framework that they work within. Have we got it wrong on occasion? Yes, we have actually. So up in Staffordshire, for example, a couple of years ago, I think it is now, we had some incidents where it was to do with the location of a defibrillator and somebody thinking there was a closer one than what was actually showing. So that person did use what they thought to be local judgment in a really difficult situation. So they are human. They do get it wrong on occasion. But when we take 4,000 to 5,000 treble 9 calls a day, the overwhelming vast majority are done absolutely bang on and spot on. And as I say, at least the calls are picked up first and foremost in an immediate sense. If any councillors wanted to come and see how that happens, we've got an open door. If you wanted to see call taking and validation taking place, you're more than welcome. We could have a small group come and see that if you wanted to. And you could hear firsthand how it happens, how we construct it, how we kind of oversee and govern it to make to get your own assurances. Absolutely, welcome to do that.
I think we'll take you up on that offer, please, Vivek. We'll organise that.
So can I come back with just a quickie? You're very kind, thank you. I remember when Bransford call centre was being closed some years ago now, and it caused a lot of public concern at the time because of the lack of local knowledge that would create in relocating it elsewhere. I think it was towards Birmingham from memory, but I can't remember. I'm intrigued by your answer because it seems to be saying two things at the same time. There's an algorithm that you have to work to, so actually the local knowledge is irrelevant. and that determines the categorisation. But then you say, because you want to be risk averse, you actually probably move the categories 3s into 2s. I think I'm trying to paraphrase what you were saying, and I guess the consequence of that, well, if that is the case, that category 3s are becoming 2s, that creates reduces capacity because of that decision making on perhaps the next call, which is an emergency. So by moving 3s into 2s, are you not creating a problem in terms of your overall capacity?
Let me clarify. It's not us doing it. Yep. So it's me making a comment on the system. Yep. So the system is inherently and needs to be risk adverse. We think, and we are. There's a national working group, obviously, because it's something a number of the ambulance trusts uses. All of the calls get coded, and we're working nationally for some of these codes to be put into other dispositions, a category 3 or 4. So it's not that our staff are moving them from 3 to 2, it's the algorithm's disposition, us wanting to have that sort of, as we move on in life, change, because actually the workload that we deal with is very different to what was going on in times gone past. It is very complex, it's frailty, it's long-term conditions, it isn't lots of car crashes and limbs hanging off and things like that, like it would have been in times gone by. It's not the world we're in anymore. So you're right, actually, when everything is, as my boss would say, when everything's a priority, then, and that's why it does need to be, we think, refined, and that's something we're lobbying for, as other colleague organisations are too.
Thank you very much indeed. Councillor Wilde, please.
Yes, thank you. I just want to return to Richard's comment about sepsis. I know you said it wasn't your area, but I just want to reinforce it because I've dealt with it 3 times this year, and the ambulance crew have been involved and they've been fantastic. In fact, there were 2 ambulances on one occasion. But yesterday's promotion on this, the concern on BBC, did indicate that only 2 of the area services carried antibiotics, and that raised an alarm. So I just want to reinforce that. But my question is actually going back to this 45-minute wait. And it's like at week 4, would we be down to the 45-minute? Where is your optimum? Do you want to be at 10 minutes, 5 minutes? What happens after 45, basically?
So, I mean, the actual standard is 15, and we should remember that, because what we don't want is for everybody to think they've got 45 minutes. Because actually, it's a really precious resource. It's, there's 410 at peak across the region with 2 staff members in an ambulance. It's an incredibly precious resource. Taking 45 minutes is too long in some respects, actually. The standard is 15. Now, to deliver a 45-minute maximum wait, the average handover really needs to be something like 16, 17 minutes in reality. That's a world would be, compared to where we have been, we'd be punching the air if we get to that sort of place. But the standard is actually 15. And because patients should arrive at hospital in an ambulance because they're really poorly, and it should be handed over almost immediately into the care of a hospital. And that should take about 15 minutes. That's the standard that we need to get back to. So whilst we're talking about maximum wait, what we would also say is that people need to remain focused on the actual handover standard, which is 15 minutes, not actually 45 is the maximum, not the standard. Yeah.
Thank you very much indeed. Before I come to you, Councillor Udall, Councillor Hardman raised his hand.
Just a very quick question for you. I do just wonder if you're measuring the correct thing. While the service is interested in how quickly it gets to the patient, and I understand why that's your priority, I would suggest to you that the patient's priority is his whole service experience. Because, of course, you don't measure then how long it takes to get to the hospital, which presumably is the sort of key bit from the patient's point of view. And I'm also, aware, living in a rural on the rural edge of the county, you know, I'm always a bit surprised, so this is the second question, as to why, you know, when they picked me up, we set off towards Cheltenham, but then we went all the way round and ended up in Worcester, because, you know, Cheltenham was only 6 miles down the road, whereas Worcester was 18. But, you know, that's clear. Well, it's a different region, I suspect, is the answer that I'm going to get. But I think you're measuring the wrong thing.
So I think the measure of response times is entirely, I would say it's entirely valid, because until you get an ambulance, you've got nobody and nothing. That is an important measure. How quickly does it arrive in? Travelling times are not something that, whilst we know what our travelling times are like, they're not something people, it's not a reported measure, it's not an outcome measure, it's not a performance measure. Never has been. I mean, it's an interesting point you raised, because you're the only person who's actually ever raised it. So it's not something we're asked to report on. Is that more important than the ambulance response? How long it takes you to actually get to the hospital? I suspect not, because at least you've got a clinician and you've got somebody with you at that point in time, and you're getting treatment being given. So travelling times aren't something that we do get report. You know, we don't report on them. We're not asked to. It's not a measured item. Just on your other point, though, around where do we go and how does that all carry on? There's been I think a positive change, and actually it was one that was done here in Herefordshire and Worcestershire before other places. So as we have differential weights between different hospitals, we would have a helicopter view, and we would be saying to an ambulance, right, don't go to Worcester, the delays are too bad, go Dudley, go wherever, go back, you know, wherever it could be. The problem is, whilst it got our ambulance and you to the hospital, it could take you longer to get to the hospital, your handover would be far more quicker. The real issue, though, is you could be a Worcestershire patient ending up in a Birmingham bed, or a Birmingham patient ending up in a Warwick bed. And then your length of stay could increase easily by half. And that's actually a really unfair thing to do to a patient, because whilst we may get our ambulance handed over more quickly, to inflict a week or two or through God knows what length of stay upon them is not a good thing. So Herefordshire and Worcestershire were one of the first to say we want to not just... So we went to all 6 integrated care boards and said we want to stop this. Patients should stay in their local areas as much as we possibly can manage it. Herefordshire and Worcestershire went one step further and said we agree, but we won't do that between Herefordshire and Worcestershire either. So we used to quite often take from Worcestershire into Herefordshire because the handover times were historically better. That stopped. So whilst patients will be potentially experiencing a longer now handover in Worcester Royal or the Alex, for argument's sake, if you're admitted and you need ongoing care, that bit's going to be far better for you. And also, if you've got ongoing care with a specialty in a hospital, it's much better to be in that hospital. So we took a bit of a some might say, well, it's a home goal for you guys, but actually for the patient, we thought it was a better thing to do. And then it's stopping us sending people from... So I've been in an ambulance, for example, in the Rugby area, and the control room said, look, the delays in Coventry are really like plus, go down to Warwick. We've had situations where I've been in Hereford and I've spoken to staff who've ended up having to go up to Stoke. So we're trying to keep our ambulances broadly in the areas they serve and trying to get patients into their local hospitals, which is better for them. I think the other thing that we wanted to avoid, the reward for having really good patient flow should not be more work. So if you've got really great patient flow, guess what? You get more ambulances in the old world. Or we stop that too, because we actually want people to think, well, if we've got really great patient flow, we're not just going to be rewarded by even more people turning up behind this. You know, it's not a great sort of reward and incentive either. So that process kicked in March, April last year. And as I say, Herefordshire and Worcestershire went one step further and have stopped it within the ICB footprint as well. So Worcestershire patients will stay in Worcestershire, Herefordshire patients stay in Herefordshire. Unless they call us to say, look, we've got a really big problem, we need some respite, then we will support them. But as a matter of routine, patients stay in their own areas now.
Thank you very much. I've got 3 people left to speak. Councillor Oodle. Councillor Hartman, did you want to ask a supplementary question? Sorry.
Well, I mean, obviously it makes sense for people in Breedon to have the county boundary movement.
I've been saying that for
Could
some
argue,
time.
but I think you could argue that on any part of the footprint where you're on the edge of the conurbation, would all I would say. Councillor Udall, please.
No, we don't want to lose Councillor Harden. We can keep him in Worcestershire. Can I ask you a question about first responder principles? I understand, and I'll stand corrected if I'm wrong, that West Midlands Ambulance Service is one of the few which doesn't actually cooperate with other first responders. For instance, the fire service, who have a defibrillator on every single fire appliance. If I was living in Pebworth, I wouldn't care if I was having a heart attack, whether it was an ambulance or a fire appliance which came out to me, and a fire appliance would be quicker because they would mobilise within 5 minutes. Is this the case, that there is no cooperation with other first responders, and that there is no working with other emergency services such as the police and the fire service in order to enable first responders to get to a heart attack victim, as a classic example, more quickly than an ambulance can get to them?
I would characterise it as no cooperation. What we said to fire and rescue, police haven't been involved in this discussion because I think they've got more than enough to be dealing with in terms of workload for sure. What we said is, if that's something that fire and rescue services want to do and get involved in, that we'd want to set them up as a community first responder scheme properly, because that means having to have our kit in terms of receiving jobs. It means having to have our training and that sort of stuff. So the governance would be really right and proper around it, and also the communications and kit would be there. No one's been forthcoming particularly around that. So it was some time ago our chief exec did meet with the chiefs of other fire and rescue services and put that out there. Some time, I mean, going back perhaps 4 or 5 years even now. So what we would support it, but from our perspective, we want it to be constructed on the basis of our other community first responder schemes, not something separate to it. So, for example, practically speaking, how do we allocate them a job if they haven't got our terminals in their vehicles, for example? It's things like that. So some practicalities and also some aspects of training around it too.
So you would be open to further discussion with other emergency services to discuss how they could actually help you with first responder principles, such as the fire service, in cases as which I've described. It's not a definite no, it's a yes but.
Yes.
You got there, Richard. Thank you. Councillor Wells, please.
Chairman, thank you. Thank you for indulging me for a second question. I'm going to break the rule that I've always set myself now, because we shouldn't really refer to our own circumstances at all when taking a strategic view of scrutiny across the NHS and public health. However, this exception proves the rule. 10 years ago, in a few weeks' time, I was taken to the Birmingham QE Burns unit. Some of you may remember this, I certainly do. I'm intrigued, and my question is a more general one, in relation to the fact there I was ringing 999, the first and only time I've ever done so, and it was a huge surprise to me finding a knock at the door about 10 minutes later from the air ambulance. I hadn't requested the air ambulance, and I'm wondering, back in we spoke earlier about how it's kind of computerised, how you respond. So in that circumstance where I was severely burnt, but no one was in a position to quantify how much at that point, how did that end up with the air ambulance, not the land ambulance?
It's an interesting comment, 'cause I used to manage the Burns unit at the QE a long time ago. 2004-05. Okay. So we've got something called a trauma triage tool, and Burns would be then considered as part of that. And so within, and you'll see it if any of you come to see us, we've got a regional, what we refer to as a regional trauma desk. So whilst it's referred to as trauma, it's actually a very broad church of injury and illness ultimately for the air. So in that case, the kind of whatever you relayed in the call made somebody believe you're starting to tick on the trauma triage tool. And then air ambulance desk, then have we got one available? Is it there? It's met the criteria. Have you got the Rolls-Royce service, I guess? I guess the other thing with Burns, though, don't forget, the other thing with Burns is the Burns units are very few and far between. So we've got QE, and then I think it's Bristol. I don't know if Oxford is even a Burns unit. So whilst some of the tertiary centres, so whilst we have university kind of teaching hospitals, not all of them are burns units. That's almost like what we'd refer to as a quaternary type service. So it's like a fourth tier where, I don't know, I think off memory, there's something like 13 of them in the country or something. So the QE serves the Midlands. So of course, the travelling time to get you there from wherever you're located. Well, I hope you're okay afterwards, you obviously were. So.
Chairman, just to say, if it hadn't been an air ambulance, I am reliably informed I would not have made it if we'd been involved in a land ambulance, because the journey time from where I live to the QE would have been probably too long. I'd gone into shock. I wasn't in a good place, and I was straight into a 7-hour operation. I don't think I'd have survived.
Just shows how reliant we are and how grateful we are to the health economy and partners. Councillor Turner, you have the final question.
It's not quite so dramatic as the last question, but earlier on we were speaking about metrics, and obviously we spoke about arrival times for ambulances to the patient, but we hadn't measured the metrics from the going back to any emergency care services. What about the metrics where we consider the time when the paramedics are actually at the patients before they actually start off? Are they making various decisions? Do we actually quantify that time? Because that's obviously, ambulance are taken out of service, the professionals are there tied up with the patient, so maybe that needs to be quantified, that metric as well.
So we refer to that as time on scene, and we do look at that and scrutinise it really closely. Time on scene has been extending and extending and extending as handover delays have been rising and rising and rising. You think, well, why would that be? 2 reasons, I guess. Whilst all this has been going on, there's more and more services being made available to us and to our staff. It takes time then to make the calls, have the discussions. That's one thing. The other thing is, if you were an ambulance crew member thinking, right, I've got this patient, could do maybe going to hospital, but I could be at the back of a 15-hour queue, or shall I try really hard to get something else? There's some of that as well. Because actually, if you've got to think, if you're advocating for your patient, sending a patient to the back of a 10-hour queue to wait maybe 2 days for a bed is a decision that they do not take lightly, because actually that does have its own detriment to the patient. It's not risk-free going to hospital to have those sorts of waits. So if there's something better or equal to, well, they're going to try and do that too. I guess there's another dynamic though. There's a third kind of, and this is us being very open and honest, there's a third staff behavioural dynamic. In times where actually the system, so to speak, used to work really effectively, if we go back to so-called good old days, so to speak, we were on our staff's back like you could never imagine. Right, you've got your patient dropped off, right, next job, everything was really, really tightly managed. But if your staff are experiencing 5, 10, 15, 20, 30-hour waits to hand over, you know what, it's not a really great conversation to have with your staff about. You spent 20 minutes too long with that patient. Sorry, God, but we're going to have a 10-hour wait over there. How you manage your staff is also how we manage our staff is really relevant, because we'd have a mutiny if we was trying to squeeze them for 5 and 10 and 15 minutes here and there and 20 minutes when they know they're going to the back of a 10 or 15-hour queue and having to wait 2 hours over the end of a 12-hour shift. So the two go hand in hand, really. We will have much more legitimacy and validity around managing time on scene if other parts of it, it's a human dynamic really with our own staff about how do you get the best out of people, and it's not to squeeze them for a little bit over there when they're being robbed for a huge amount over there. That's just being honest.
Yeah, thank you very much, and I think it is being very reasonable, isn't it? Thank you. That brings to the end the questioning. Vivek, thank you so much for coming along this morning. Yes, definitely. I think you've already got the job, actually, if you don't mind me saying. Can you pass our sincere thanks on to the West Midlands Ambulance Transport? And you're fantastic. When you're there in the hour of need, it's that confidence when you come through the door. We think we've all, or many of us will have been on the end of a call and had to take emergency action. I think it would be useful in future meetings to deal with patient flow at the same time as we invite you back. Yeah, and I think we'd like to do that probably around May, June time, but I'll talk to the committee in a moment, because I think it'd be important to gain momentum with the proposals that are going on now. And this is day one.
And that sort of thing does need your scrutiny. So when this was being set up, for example, we would say, you know, we want these plans to go to individual trust boards, because boards need to hold their organisations to account, just like you hold us to account as organisations too. If we've set out to do something really big to recover something, well, there should be some scrutiny over it. So yeah, I would welcome that. Thank you.
Thank you very much. I also think we need to build some confidence back into the system, because headlines like 6,500 lost hours, they create negativity and anxiousness amongst the public, and I think we have to scrutinise it. We're all open to scrutiny, aren't we? But I want to see a forward positive trajectory, and I want to support you in the work you do. So thank you. Thank you so very much. Health Watch, have you anything else to add? As Simon Adams gets to stand up.
I was just getting up. No, I mean, thank you, Vivek. Thank you, Phil. I was just reflecting on how, you know, many years ago I was a cop, and ambulance staff didn't spend much time on scene because all they could do was scrape people up and put them in the ambulance and ship them off to hospital. Now the roles changed completely, and you can't train people to be clinicians and expect them to deal with people on the scene and hopefully not have to take them to hospital without that taking time, can you? So the roles change just massively.
This is actually an interesting point, because if my chief exec was here, he would say I could create the most efficient and cheapest ambulance service in the country, because I'll just say to my staff, you get them in the ambulance and just go to hospital. Stop doing anything that you're doing about calling this and referring that and pathway this, just send them all. But that's not the way we can, obviously it's not the way we could work. It'd be the most efficient thing we could do, but it would break the healthcare system completely. So I guess health and social care is just ever more complex, isn't it? That's what
Absolutely
we're dealing
is. And as people live longer, it becomes even more complex. So thank you again, Vivek.
Thank you.
Thank you very much, Simon. Thank you very much. So the next agenda item is the work programme, please. We have it before us. We have March and April's meetings assigned. I think the point that we've just discussed we should look at around patient flow and the ambulance service, I think we should align those two subject matters, if you're all in support, on a future agenda item. I think we need to monitor this situation closely. Everybody in agreement? Yeah. So potentially if we could get that in... Pardon? I dare not disagree with you. If possible, please. Any other items that somebody would like to bring forward sooner?
We've picked up some stuff today.
Yeah, and we've picked up some actions here today, which were the link to Healthy Start. Sorry, could you scroll down? The Public Health Link to Healthy Start scheme to be shared with HOSC. Provide a report back to HOSC on the outcomes of the current vaccination campaign, showing outcome data. And future reports include reference to highlight the more changing areas in public health, areas in public health. And the West Midlands Ambulance Service provide an update on the maximum weight protocol and outcomes to HOSC. Add this to the work programme. Health Watch feedback on work in ED starting in March, and update HOSC when the work is concluded. And then sepsis. Will the West Midlands Ambulance Service receive training on this, and will ambulances carry out antibiotics? And then Vivek will provide further information about HOSC, how we can support on an independent capacity review. And then Vivek is to provide data on patient satisfaction and outcomes. Sorry, I'm reading this from far and my glasses don't stretch this far. Agreed to arrange a visit for HOSC to the West Midlands Ambulance Service call centre. I think lots of nods around the room when that was mentioned. Is there anything else that you'd like brought forward at this moment in time, please, onto the work programme? Councillor Kumar, excuse my back.
Sorry. I think there are two good topics which haven't been discussed for a long time. One is about frailty and progress with implementation of the new strategy, which hasn't been looked at since 2023. And the most important thing, which we have touched on in the past, but not completely, is end-of-life care. It hasn't been dealt with for a long, long time. So perhaps worthwhile looking at it, because it can be quite traumatic for families who have got terminally ill people. The pathways are not that clear. I think worthwhile thinking about it. Thank you.
Is the committee in agreement with those two suggestions to come forward, please? Okay, that concludes the meeting, the Health Overview and Scrutiny Committee. Thank you all so much for your attendance. Thank you for your participation. Thank you.